Hello everyone. Today we'll be talking about hypercapnia, and the etiology we'll discuss is decreased minute ventilation. In the previous lectures, you have understood that CO2 diffuses pretty fast. It takes less than 0.1 second to go from capillaries to the alveoli, and hypercapnia therefore almost always arises from inability to get out of the alveoli to outside air. You also learned that hypoxemia from hypoventilation responds very well to oxygen. We learned in the previous lecture that carbon dioxide increases mainly because of three factors: increased production, decreased minute ventilation, or increased dead space ventilation. Now, the respiratory control is present in your pons and the medulla. There are various pontine respiratory group and medullary respiratory centers. These get input from your pulmonary stretch receptors and peripheral chemoreceptors and give output to respiratory muscles. We have got central neurons in the brain and peripheral neurons in the carotid body. Carbon dioxide is a neutral molecule, so it's able to cross your blood-brain barrier pretty easily. However, the hydrogen ion and the bicarb ion are charged molecules, so are unable to enter the blood-brain barrier. When carbon dioxide enters your CSF, it dissociates into bicarb and H+ ion, and this hydrogen ion would be the stimulus for your central chemoreceptors. Once these chemoreceptor sense increase in hydrogen ion, they will increase the stimulus, which will go towards the phrenic nucleus and downward to the respiratory muscles, and thus increase the minute ventilation. Carbon dioxide in the blood also dissociates into bicarb and H+ ion, and this hydrogen ion is sensed by the peripheral neurons in the carotid body and sends stimulus to the central respiratory nuclei. So the carotid body senses more acute changes in carbon dioxide, while there is a slight lag of sensing carbon dioxide by the central chemoreceptors. So contribution to minute ventilation is much lower by the peripheral neurons than the central neurons. There are two potent stimuli for the respiratory center, the low pH and hypoxia. Low pH will result in increasing respiratory rate and tidal volume by stimulation of both central and peripheral chemoreceptors. This will result in something you call respiratory compensation. The second stimulus is hypoxia, which would similarly result in increased rate and tidal volume, decreasing the PaCO2 and increasing the pH, causing respiratory alkalosis. If there is a problem with your neuromuscular system, despite being stimulated by low pH and hypoxia, there will be no increase in rate and tidal volume. In fact, these will be lower so as to retain the CO2 and cause respiratory acidosis. So what causes a decrease in minute ventilation? Problem with the peripheral chemoreceptor in carotid body, such as in resection or ninth nerve compression, would result in decreased minute ventilation. The respiratory center in the pons and the medulla can be affected by infections, bleeding, stroke, trauma, and medications. The output from the respiratory centers go through the spinal cord and to the diaphragm via phrenic nerves, and any injury or involvement of this pathway would also result in decreased rate and tidal volumes. So lesions like transection of spinal cord and polio, Guillain-Barré syndrome, muscular disorders like myasthenia gravis and myotonic dystrophy can all result in decreased rate and tidal volume. Thoracic case abnormalities like obesity, kyphoscoliosis, or obstruction of the airways can also physically reduce the tidal volumes and can result in decreased minute ventilation. Whenever you are dealing with decreased minute ventilation, your workup for the neuromuscular pathway would possibly include imaging studies like CT and MRI of brain and the spinal cord, a lumbar puncture, nerve conduction studies and electromyography, and muscle biopsy. It's very important to know the course of phrenic nerve, as any trauma or pressure on the phrenic nerve through its course can affect your diaphragm. One of the reasons for phrenic nerve injury is coronary artery bypass graft, which can result in phrenic nerve paresis in 10 to 60% of the cases. One of the other common diseases that you will be encountering will be critical illness neuromyopathy. Your patients can become very weak once they are on the ventilator, and studies have reported that force generating capacity of the diaphragm is reduced by 32% after 5 to 6 days of mechanical ventilation. And on biopsies, they have found that the muscle fiber cross-sectional area is reduced by around 25%. Atrophy can start within 18 hours of being on ventilator. There are two main types of muscle fibers in the respiratory system, and there are type 1 and type 2. Type 1, as you remember, these are slow fibers and they're fatigue resistant. And these type of muscle fibers are found in the muscles of posture and respiration. The type 2 fibers, on the other hand, are fast fibers, but they're easily fatigable, and they are useful for expulsive effort and active movements like your biceps. In patients with COPD, type 1 fiber increase in number, while type 2 fibers, they decrease in number. In steroid myopathy, the type 2 fibers are significantly reduced. In patient on mechanical ventilation, there is an atrophy of type 1 fibers. So these guys are easily fatigable. The common way of measuring muscle weakness is using maximum static inspiratory and expiratory pressures. You can also use sniff pressure to figure out how much force is generated by your inspiratory muscles. However, all these tests require good patient cooperation and a good seal around the mouth. If you are specifically looking for diaphragmatic palsy, you can use a sniff test with fluoroscopy, where you can observe the diaphragm movement with inhalation. Or if you observe 20% reduction in forced vital capacity in upright and supine position, this would be suggestive of diaphragmatic weakness. In ICU, you can perform maximal inspiratory and expiratory maneuvers on a ventilated patient. And again, the same limitations arise as it requires patient cooperation. And certainly in ICU, this is heavily influenced by sedation level, anxiety, and pain. In a ventilated and sedated patient, measurement of PI max during a 20-second end expiratory occlusion gives you a better value. You can also use P0.1, which is the airway pressure generated in the first 100 milliseconds of inspiration, but P0.1 is dependent on the lung volumes, and they are most reliable when end expiratory volumes remain constant. The sensitivity of P0.1 is around 86%, however is not very specific. As you can see, the specificity is around 58%. So none of these tests that we talked about have good specificity. So use more than one measurement if you want to diagnose neuromuscular weakness. It's easier to rule out than rule in. Whenever you are called to evaluate a patient with hypercapnia on ICU or the floor, these patients either have acute or acute on chronic hypercapnia. Obtain a quick history. These patients will be breathing slow and shallow, and they may not show any signs of distress because of muscle weakness. On exam, pay stress on neurological deficit, muscle tone, examine their eyes and lids, and check for reflexes. Observe for any paradoxical abdominal movements and asymmetric chest movement and any chest wall anomaly. Auscultate them for wheezing and loss of breath sounds. Always look at the medication list and recent medications given. So always discuss this with your nurse. Any medication that can make obese patients with OHS sleepy will cause hypercapnia in these patients. Get a blood gas to confirm hypercapnia and go through the differentials as we discussed previously. Order further testing depending on your clinical suspicion. Understand that CT brain is not the best at evaluating the posterior fossa, so you might need investigations such as MRI. One of the problems with hypercapnia is that hypercapnia itself will cause worsening of mental status even further. Whenever you see such patients, try to figure out if you are dealing with acute or chronic hypercapnia or a combination. Figure out if you are dealing with decreased minute ventilation versus increased dead space ventilation, and always remember the differentials. So how do you distinguish acute from chronic hypercapnia? There are two ways to figure this out. If you don't have ABG, look at the baseline bicarb, and best number will be to look at the basic chemistry on admission, and the rule is bicarb will rise by 6 for every 12 increase in PuCO2. Normal bicarb is around 24 and normal PCO2 is 40. So if patient has bicarb of 30, the baseline PuCO2 will be 40 plus 12, that is 52. If you have ABG, the pH will fall for 0.1 for every 12 increase in PaCO2. So if the ABG shows pH of 7.3 and PaCO2 of 66, that would mean this drop of 0.1, that is from 7.4 to 7.3, was caused by 12 of PaCO2. So your PSO2 started with 54, that is 66 minus 12. So 54 is your baseline PSO2. So this patient is possibly has chronic hypercapnia at 54 and acute component of 12. We'll discuss this in more details when we talk about management of hypercapnia. Treatment principles for hypercapnia include treating the underlying cause, treating associated hypoxemia, and treating hypercapnia. Finding the cause goes a long way in treating hypercapnia. Hypercapnia occurs while in hospital. Think about acute causes and also think about chronic predisposing factors. Most often, the depression of respiratory center by opiates or sedatives is the commonest cause for hypercapnia while in hospital. Other things like stroke or bleed in the pons or medullary area can result in hypercapnia. Pinpoint pupil can be suggestive of either opiate overdose or pontine bleed. Other diseases like high cervical injury, heart surgery, Guillain-Barré, myasthenia gravis can also result in hypercapnia. Naloxone is the reversal agent for opiate overdose, so keep it handy. You can also use flumazenil for benzodiazepine overdose, but understand that it can cause seizure in patients who are chronically on benzodiazepines. Hypoxemia in hypoventilation will respond beautifully to nasal cannula, and even with 3 to 4 liters per minute, your SATs will be normal. If the patient is requiring a higher FiO2, you can suspect that something more is going on with the patient, or a patient is not breathing at all. To treat hypercapnia, you have to increase the minute ventilation, and this you can achieve by increasing the tidal volume. In an unintubated patient, it's very difficult to increase the respiratory rate on these patients. To increase the tidal volume, sitting position is the most optimal in increasing the rib cage excursion. So attempt to sit up your patient as much as you can. If the patients have slid down in the angle of the bed, their belly pushes against the diaphragm and decreases their tidal volume. So pull them up in more upright position. You can also put them in slight reverse Treadland-Burke position, which can take the weight of the belly away from the diaphragm, and this can increase your tidal volumes. Always keep bag and mask ready whenever you're dealing with hypercapnia from decreased minute ventilation. Always have a PEEP valve ready, as this will help recruit the lungs and prevent atelectasis. You should always know how to hold the mask, and I would advise you to practice this on mannequin. If the things are getting worse, you can use non-invasive ventilation. CPAP is typically not a good idea for these patients, but bilevel is. So let's understand why we need to use bilevel rather than CPAP. So this is your normal alveoli. At the end expiration, your lungs are at functional residual capacity, and when you inhale, you generate a tidal volume, and that is shown in the dark blue area. When you apply the CPAP, your FRC increases, and when you inhale, you don't get any extra support during inhalation because the pressure remains the same. Your tidal volume may in fact be slightly lower than the previous as you are breathing at higher FRC. When you apply BiPAP, you apply a differential pressure during inspiration and expiration. So the EPAP, that is the lower number, is same as the CPAP. And when you give that differential pressure during the inhalation, that gives you increased tidal volume. Think about CPAP as a form of BiPAP in which the IPAP, that is inhalatory pressures, and the exhalatory pressures are the same. So EPAP will govern how much your FRC increases, and your driving pressure governs how much tidal volume increases. Therefore, if you are treating a patient with sleep apnea, atelectasis, or want to counter auto PEEP, use CPAP or increase the EPAP on the BiPAP. But if you want to increase tidal volumes, use BiPAP and increase the driving pressure. In some patients with sleep apnea and decreased minute ventilation, you may need to increase the EPAP to overcome the obstruction and increase the driving pressure to increase the tidal volume. So see what your patient exactly needs from you. Do not use non-invasive ventilation if your patient is in respiratory arrest, if your patient has impaired consciousness and unable to protect airways, or there is a recent facial trauma or esophageal surgery. Try avoiding non-invasive ventilation on patients and have secretion clearance issues. For non-cooperative patient, you can use dexmedetomidine to see if that can reduce their anxiety. Avoid giving them opiates or benzodiazepines. You can use backup rate in the ST mode of BiPAP to increase the respiratory rate. However, the volume delivered are pretty small and may not be optimal for a patient to remove carbon dioxide. Stay away from the high flow in these patients, as this will not make your hypercapnia better. It can provide oxygen but not the ventilation. If the patient has not responded to bilevel or has contraindication for it, think about invasive mechanical ventilation. So in summary, when you suspect somebody has decreased minute ventilation as a cause for hypercapnia, go through your differentials from the respiratory center to the level of respiratory muscles, get a good history, and perform a detailed neuro and respiratory exam. Try to correct the underlying etiology and predisposing factors. Differentiate acute from chronic hypercapnia. Hypoxemia would respond very well to increase in FiO2. To increase the tidal volume, raise the head of the bed, use slight reverse Trudlenberg position, avoid wedging, and keep bag and mask with a PEEP valve ready. Use bilevel or BiPAP if the patient can tolerate. Do not use high flow. And in case of contraindication or failure of BiPAP, use invasive mechanical ventilation. Thank you.